And our task will be related to predictions and prognostications. I mean, are we able, using data, mainly coming from, at the beginning, MR, but as we will see, MR is not enough to explain things. We need to be more mind broader and incorporate so many different aspects of the environment, the different systems, and different variables linking to the disease to make accurate predictions and prognostications. And, and at the end, I will share with you why really taking care of data is extremely important. And before we go into data, this is, in my understanding, was the difference between and why we have to go deeply into concepts of truth and predictions. And we have to realize that exact sciences, such as physics, are grounded in the demonstrations of certainty, aiming to uncover objective truth. And the evidence is based on mathematics and the absence of proven errors. And we understand that sometimes that will also happen in medicine. But medicine is not an exact science, it's an experimental science. And medicine rely mainly on evidence and do not aim at all for absolute certainty, but for the most effective approach through causal, and thanks for raising causality, inference, focusing on minimizing the risk of errors. So we try to be as accurate as possible or as feasible. And medicine is pretty sure an experimental science. And what we mean, and we speak on evidence, we are referring to the collection of data where evidence is based. And data come from research, studies, patient outcomes that will, through the appropriate methods, supports or refutes the effectiveness, safety, and applicability of a diagnostic method or medical intervention. And at the end, data is used by data-driven and hypothesis-based researchers. So data and evidence come from the real world. And in some way, we are trying to enlarge the amount of data by using the so many different data collections and sources that are generated every day at the experimental and hospitals, institutions. So data has to represent the real world, needs to be large, heterogeneous, diverse, and interoperable between the different variables to obtain those statements beyond the known data we are evaluating to be reproducible or universal on their results and explanations. And data need to be extrapolated from the local cohort we are evaluating to the general populations if we want to make right predictions and prognosis. And models, those prediction or predictive models, need to integrate all the relevant inputs or variables who will be predictors to approach causality. And that means that we have to take into considerations the so many confounding variables and explainable variables, interaction and nonlinear relationship. And that's extremely important to avoid biases. And on real-world data design studies and the need to create models, we have to define that biases, which are a feature that makes evidence misleading, coming from the design, the execution, or the analysis of the study, needs to be solved or to be considered. And in some way, bias detection needs critical thinking. I mean, did we incorporate all the relevant variables? But also contrafactual thinking. I mean, what will happen if we just change minor conditions at the beginning or within the inputs of the model. So taking care on the data quality, validation of the data we do have is mandatory. And thinking on prognostic factors, we have to recognize that the most important issue is to improve the way we are thinking medicine today. Whatever we do, coming from experimental research to clinical practice, have to have finally an impact on the patient's healthcare pathway. And this is one example. This is when we want to make prognosis in patients with lung cancer, the most important issues relates to the staging, which is relatively simple, is size, lymph nodes and metastasis, but also histopathological profile, but also some markers of aggressiveness coming from molecular and genetic expressions, and even relevant clinical variables and comorbidity. I mean, do I have diabetes or a previous stroke or whatever? And by doing that, we have our prognostications on survival. And if we want really to improve that, we have to incorporate metrics that will allow us for the fine-tuning of those predictions to perform precise medicine. So we have to go into patients' outcomes. No? We want to predict or prognosticate. And our current cancer guidelines rely on evidence from large and randomized clinical trials, which are not real-world data. And physicians are aware of the pitfalls associated to applying population-based data to the individual patient you have in front of you. Because in so many times, maybe 10, 15, 20%, the predictions will not be accurate. So on the personalized medicine, we have to be much more accurate predicting treatment response and prognosis, having knowledge on the effect of the different drugs and treatments on a specific patient. And to do that properly today, we can use AI, prediction models, solutions towards that personalized treatment approaches, taking advantage on the use of data integration. I mean, not only clinical data, but also molecular imaging, which is radiomics and digital pathology, to be able to make better predictions on the daily clinical practice. And which predictions do we want to make? Well, we want to make predictions by using diagnostic panels on susceptibility, that's the risk to develop a disease, phenotyping, that's to understand the specific disease expression of subtype we do have in front of us on one patient, prediction, which means a favorable or unfavorable treatment effect on a specific drug, of course, safety, which is toxicity or adverse events, and prognostication, which at the end is recurrence, progression, or patient survival, which is extremely relevant in oncology. And we can incorporate new data into these models by using imaging biomarkers or radiomics. This is model-driven. We can use morphology, semantics, histogram distribution, spatial distribution, matrix, dynamic changes. Of course, we have to go through data reduction, robustness, then incorporate statistics or signature clustering, but at the end having candidate biomarkers to explain a condition and incorporate those biomarkers into prediction models. But more and more, today we can also use AI tools to go directly from medical images to the prediction models, maybe solving some of the troubles on reproducibility or uncertainty related to the so many different images coming from the real world, from different vendors, different protocols, obtained or machines with different releases or whatever. So on the biomarkers and models, we do have so many available measurements of features that will explain phenotypes or habitats or invasiveness, aggressiveness of the lesions, and then we can use statistics or AI models as generators of diagnostic panels that will be incorporated into those clinical prediction tools to guess which will be the best treatment for a patient. And we do have so many examples over the last 10 years on the use of these biomarkers to guess issues such as prognosis, mainly overall survival, with a really high accuracy when we do that on a control or single center basis. But when we try to incorporate those biomarkers into different other hospitals, we always see a decrease on effectiveness and accuracy based mainly on the variability and non-reproducibility of the results. These are some examples on glioblastomas and survival, or even by using AI, picking up those areas within the prostate that will have a clinical significant probability of having a tumor that has to be treated. And that's also extremely relevant. And we can do, of course, we can link biomarkers by using nosologic multiparameters classifiers. We can incorporate more and more complex processes to guess those prediction models. And on all that pathway, coming from the clinical hypothesis to the images, the processes we are doing, such as segmentation, reduction, resizing, preparation, harmonization, and so on, going through feature extraction, data integration with genes, markers, and pathology. And at the end, the endpoints, the outcomes, estimations we want to predict, like survival or aggressiveness or invasiveness or response to treatment, we have to think all the time on how, if we can trust on the data we are using, which is the best truth we can use for those variables to construct those models. And then we have to go into the relevance of that data we are gathering and the study design. And in most centers, of course, we can always perform experimental studies, but then those will be time-consuming and long in time with less amount of patients that going through observational studies. And for observational studies, we can use the real-world data collections we do have in the hospitals. We can extract data from those PACS systems or electronic health records. We can do that also retrospectively or prospectively, but even if we do that on an experimental or observational, both are valid. We can obtain models from both. And the main important aspect is that data has to be controlled. And differences are related to the data quality, that means completeness and control of biases, and of course on cost. And data selections from multiple disciplines, not only MR, is a critical component of a robust study design, because to explain whatever outcome, we really need to integrate data, high-quality data, coming from pathology, molecular, imaging, clinical, comorbidity, and so on, to really produce robust models that will be used in a clinical practice. So to construct these models, in some way, we have to recruit and split our data sets in a way that will be able to avoid biases. And we have to go into the training and validation data sets. And for the validation, it's extremely important that we have on that part to tune the model hyperparameters and configurations and to be paired with the training data sets to prevent model overfitting. And finally, and it's mandatory, we have to have also a test set, which means a fully independent data set coming from different places, machines, maybe areas or countries that will be used to verify the model's performance as an unbiased metrics for generalizability, for universality of our models. So on the design of these datasets constructions, we have, of course, to go both on prospective and retrospective analysis on the inclusion and exclusion selection criteria, on checking for the sample size evaluation, data partitioning, how representative is our data on the spectrum of the disease we want to evaluate. We have to go through class balance sampling and mainly multi-center recruitment, and then split our data into the discovery and independent test on whatever percentages we want. This is just an example. And going to the construction and repeatability analysis, and then reproducibility. And one important issue on data collection and biases is that we have to consider, as in this paper highlights, the absence of a streamlined workflow, low quality input data, heterogeneous data as maybe biases, and we of course have to improve workflows, standardize protocols, reports, protect time to do that. And in my understanding, input bias in our data will introduce models to be unreliable, reducing generalizability, and that's why we need to go into the standardization and interoperability of the data, going through the common data models, and so on. And I just was willing to share with you one of our large projects on multi-scale approach to clinical decision support systems, defining prediction models. And this is a case for neuroblastoma. Neuroblastoma is a malignant, aggressive tumor in children with extremely high variability behavior. We do have tumors that are not really aggressive and other ones that are extremely aggressive with metastasis and the need for quite a strong treatment on them. And our hypothesis was that maybe we should be able to improve the decision-making process in these children by using data coming from the real-world scenarios on hospitals and clinical trials all over Europe in so many different institutions, evaluating their clinical episode once it was finalized to train and validate the models, and then test those solutions on a fully independent new data sets. To do that properly, we have to go through the inclusion and exclusion criteria, random-like allocation, imaging features extractions, common data models, stratifications, estimation of the effects, and we need really a multidisciplinary team approach, because no one at the hospital level is able to manage children, genomics, pathology, molecular, data structuring, IT, biomarkers, development, and so on. And this was, or is, our pathway. We try to define this virtual biopsy concept, meaning that we do have inputs coming from the MR studies of these, at the end, 1,100 patients. we developed a fully automatic AI tool that detected and segmented the tumor without any interaction. The only approach was that after that identification and segmentation, a radiologist was checking and maybe editing, a minor editing of the contours of the tumors on a 3D analysis. Then we went through the hallmarks extractions, features obtained through radiomics analysis that were then checked for redundancy and replications. We linked that to the diagnosis and predictions outcomes we were really willing to modulate, to obtain, and that was related to classification and also regression with survival, cellularity, and angiogenesis related to drug definitions. And at the end, we were willing to incorporate them on the decision pathway, meaning the probability of treatment response, the levels of confidence, treatment modifications, and also impact in randomized trials. And before we did that, we were needed to go into data curation because there was a huge variability on the sequence identifications, annotations, time coherence tools, quality check tools on how the data was structured. And we did that on a fully automatic way nowadays, in some way exploring not only images but also clinical and molecular data. We then faced the troubles of the uncertainties related to the different machines, MR machines that was used on the last 9 years, the different protocols, acquisition parameters, and so on. And we went into data harmonization. And now we develop our pathway for data harmonization, and we are quite happy that we did prove that it works, at least on the neuroblastoma cases and on T2-weighted sequences, and we are really able to minimize the influence or to avoid or to take out the changes related to the protocols and the machines, and to keep only those changes related to the disease to obtain those models. So this is the full pathway. This is, we wanted not to develop new models, but to improve the already existing models. We really wanted not to make a new discovery, but to perform things better than we are doing before. Therefore, we did incorporate, of course, oncologists on a platform as a clinical decision support system. We did incorporate on that platform all the data relevant to the risk stratifications based on molecular pathology and clinical status. We did incorporate the AI detection and segmentation tools and features extractions. And then we created models, and that's the report we provide today to the oncologists with the explainability on which features are being used, and the re-staging on groups based on survival of these patients. And this is one of the examples we did have just a few months ago. We have 2 kids. Both of them are of high risk based on the standard approaches to risk stratification, but when we did incorporate our new clinical decision support systems, patients were reallocated in different risk groups related to survival. So our feeling is that now we have to do that, or we are doing that, in fact, in a prospective way to prove with new children which is the clinical impact of these AI decision support systems that are presented to radiologists and oncologists on an extremely fast way based on AI achievements. and willing really to incorporate interactions with physicians, continuous learning on whatever is done, willing to decrease uncertainties when we manage these patients. And to decrease uncertainties, and going again into data and the relevance of data, we really have to try to rethink which variables or inputs might be integrated or might be confounders or even relevant for causality on these prediction models. And that's the example of the exposome, and we are really rethinking if data related to inflammation, metabolomics, other genes expressions or epigenetics, but also external or personal changes might improve our prediction models by considering confusion, collision, and mediation effects on these issues. And we are really willing not only to predict disease prognosis or response to treatment, we were also willing to predict issues as aging of the organs, because in these patients and the overall population, MR and imaging and biomarkers and radiomic features can be used to evaluate also which is the age of your tissues and organs, and those are just some examples we are doing. We can predict now bone age, brain age, and some other organs. And this is my one of the last slides on causal inference, because even if we are doing observational studies, we should be able to provide some insights into causality, being able to evaluate temporality, consistency, coherence, and analogy of the models we do have with the predictions. And just to finalize, if we need data, then we need millions of cases, not just hundreds. And to do that, this is an extremely nice initiative coming from the European Commission, is the construction of an European Federation of Cancer Images infrastructure to help researchers. On that infrastructure, we provide with millions of images to do AI on image harmonization or denoising, segmentation, detection, or whatever. But also, we are linking so many different hospitals, allowing their electronic health records to be checked on quality, interoperability, standardizations, to allow researchers to extract the data where the data is generated on an extremely fast way, and not using most of our time looking for the data, but using our time to perform research on the data. And the benefits of that initiative, which is, I will be extremely happy if you can take a look to that, are for researchers, because there will be an environment providing access and processing of images. Also for companies or innovators, we really want to help them on the regulatory pathway. We, at the end, want to help physicians to be able to validate the tools and to collaborate on the needs of those outcomes on diagnosis, prognosis, and treatment response. And of course on citizens, no? Because we understand that at the end, if we do this for the best of us, no? as citizens, we will empower citizens on these clinical improvements on prediction models. And this is thanks to my group, and also thanks again for the organization allowing me to share some thoughts with you. Thank you.